Restless Legs Syndrome, also referred to as Willis-Epcom disease, is a neurological condition characterized by a strong urge to move the legs. The exact mechanism is not fully understood, but the pathophysiology mainly involves low iron, dopamine dysfunction, and other neurotransmitter problems. Let's explain this in detail. Dopamine is a neurotransmitter with multiple functions. Its effects depend on where it is produced and which neural pathway it acts on. In RLS, dopamine activity in areas such as substantia nigra, basal ganglia, and the thalamus is especially important. These brain regions are involved in motor control and modulation of sensory input. Sensory modulation means inhibiting or filtering out irrelevant and repetitive sensory signals. Dopamine helps prevent unnecessary sensory information from reaching conscious awareness. In terms of motor control, dopamine helps initiate, coordinate, and smooth voluntary movement. Iron plays a critical role in dopamine synthesis and in maintaining normal dopamine pathways. In patients with RLS, iron levels are reduced in the central nervous system, particularly in the substantia nigra, even when blood iron levels appear normal. In summary, RLS is strongly associated with reduced iron availability in the brain, which disrupts dopamine and related neurotransmitter systems that normally suppresses unwanted sensory signals and movements. This dysfunction is more noticeable at night, leading to abnormal leg sensations and an irresistible urge to move while at rest. Restless leg syndrome can be primary or secondary. Primary RLS is idiopathic, meaning that there's no identifiable cause. However, it tends to be inherited and has a genetic component. Symptoms can begin as early as childhood and are often misdiagnosed as growing pains during childhood. Secondary RLS occurs due to an underlying condition or a process, such as pregnancy, chronic conditions including iron deficiency, vitamin B deficiency, renal failure, Parkinson's disease, peripheral neuropathy, and other inflammatory conditions. Also medications, especially those that affect dopamine, such as antidepressants, metoclopramide, and antihistamines. Patients may experience a recurrent urge to move the legs, which is relieved by movement and becomes worse at night or during rest. Symptoms can also be associated with PTEX or PTICS, including pain, although this is not very common, pins and needles sensation, tickling, itchiness, and crawling sensations. In many cases, patients may have periodic limb movements, which are twitching movements of the legs and sometimes the arms that occur during sleep. Although patients are often unaware of these movements, they can disrupt sleep, and as a result, quality of life may be affected, leading to poor concentration, increased daytime somnolence, and reduced performance at work or school. They may also experience other sleep disorders such as insomnia. RLS is a clinical diagnosis. We should do a proper family history and a medication review. A complete physical and a neurological examination should be performed. Lab tests may help identify underlying causes and can include an iron profile, renal profile for uremia, and a pregnancy test. Additional investigations may be considered based on clinical suspicion. The diagnostic criteria for RLS include an urge to move the legs, associated with uncomfortable sensations, symptoms are worse at night, worse at rest, relieved by movement, and are not better explained by another medical or behavioral condition. In secondary RLS, we should treat the underlying cause, such as iron or vitamin B deficiency. For pregnant patients, non-pharmacological interventions are the mainstay of treatment because most pharmacological agents are contraindicated. In primary RLS, if symptoms are mild and not disturbing, treatment should begin with non-pharmacological measures. These include avoiding caffeine, nicotine, and alcohol, as well as using leg massages and warm baths before bedtime. Compression or vibration wrap devices may also help reduce symptoms. Pharmacological treatment includes gabapentin enacarbil and pregabalin as first-line options. Dopamine agonists are another option, such as pramipexole. The levodopa-carbidopa combination may also be used, and in this combination, levodopa is converted to dopamine in the brain, while carbidopa inhibits the enzyme that breaks down levodopa, increasing its availability in the CNS. Benzodiazepines and low-potency opioids can also be considered.
If you have any feedback or ideas to help us improve the channel, let us know in the comments. And don't forget to like, subscribe, and turn on notifications. Thanks for watching.